Hello, on today's episode of Intern Crash Course, I'm discussing yet another situation that all interns face, despite most never receiving formal training in it: how to pronounce a patient's death. When I was an intern, I think this situation was the one in which there was the largest gap between how relatively straightforward this is, and yet how intimidating it felt the first couple of times I did it. Let me break down the steps to make you incrementally more comfortable. Assuming this doesn't immediately follow an unsuccessful code, the typical circumstance that leads up to a pronouncement is that you'll get a call from the bedside nurse stating that one of the patients you're covering, either your own primary patient or a patient you are cross-covering, has died, and the nurse would like you to come pronounce them. When you take this call, ask the nurse 3 specific questions. Was the death expected or unexpected? Is the patient's family present? And if so, how are they doing? Meaning, are they grieving? Are they in quiet shock? Are they angry? Etc. And has anyone else been notified, such as the primary attending? If the death was unexpected, head straight to the room. It is extremely rare for someone to get this wrong, but it's not impossible that the patient is not actually dead, in which case there may be emergent things that should be done, even if the patient is DNR and close to death. If the death was expected, for example, someone on comfort care measures, I'd recommend doing a very quick chart review before entering the room to perform the exam. And by quick, I mean no more than 3 minutes to read over that day's progress notes and look over what meds the patient had been on for comfort, assuming that you don't already know the patient. It isn't common, but once in a while a family member will ask a very straightforward question about the death. But do not keep either the family or bedside nurse waiting while you read all the details of the hospital course. Almost everyone feels some degree of discomfort the first time they're in a room alone with a dead body, which will be amplified if it's also their first pronouncement. So, if it is your first pronouncement, it's totally fine to ask your resident to accompany you. And if your resident is not available, it's okay to ask another intern or even ask the patient's nurse. When you get to the room, if the family is present, here are some pointers. Introduce yourself and explain that you are here to officially pronounce their loved one as deceased. If you are cross-covering for another intern, explain to the family that you've had received sign-out from the primary team and were aware of the patient's condition and possibility of passing. Express empathy with very general statements like, "I'm very sorry for your loss," but avoid more personal ones like, "I know what you are going through," because to be honest, you really don't. Don't talk too much. The family usually is not interested in a conversation with a doctor at this particular moment. Don't ask the family to leave the room for the exam, but do give them the opportunity to do so if they prefer. If the death will not be a coroner's case, to be discussed in a minute, ask the family if they've considered requesting an autopsy. This decision by the family does not need to be made right away. Ask if they have any questions, and offer pastoral support if it's available. The typical pronouncement exam is short and simple. It does not take much to determine a patient is dead. First, confirm the patient's ID. Writing a death note on the wrong patient in the chart is really awkward to undo. Check for a response to tactile stimuli. You don't need to assess for overt pain with needle prick or do a sternal rub, but grasp the hands or pinch a nail bed out of view of the family. The reason for this is that if the patient is merely unresponsive, has a weak pulse, and is hypoventilating, which is the typical state immediately before death, a returned hand grasp or a grimace to nail bed pressure is a really quick way to ascertain that death has not yet occurred. Next, check the pupils for their position and response to light. They should be fixed and dilated. Palpate for the patient's carotid pulse and watch the chest for spontaneous respirations. In the final moments of life, a pulse can be extremely slow and erratic, and a patient may only be taking a couple breaths a minute. So palpate and watch for at least 60 seconds. Some recommend as long as 2 to 3 minutes. Then, to be absolutely sure, listen for heart sounds for another 60 seconds. The time when your exam is finished becomes the official time of death. Surveys of families have found that using a smartphone at the bedside to determine the time of death is negatively perceived, so either use a wristwatch or the wall clock. After pronouncing the patient, you need to decide if the coroner should be notified to determine if an autopsy is required. You should discuss the death with the coroner immediately after pronouncement if any of the following are true. The patient died within 24 hours of admission. The death was associated with trauma, even if the trauma did not appear to be the direct mechanism of death. The patient died from a suspected suicide, homicide, or accidental poisoning, including drug overdose. The patient was an infant who was suspected to have died from SIDS. The death occurred during a medical procedure or was from suspected malpractice. The likely cause of death is unknown, or the death has any other unusual circumstances not otherwise listed. Now, just because a patient's death may meet one of these criteria does not necessarily mean that the coroner will decide that it's a so-called coroner's case requiring an autopsy. For example, if a 90-year-old woman with advanced dementia was admitted for aspiration pneumonia, who then codes 6 hours after admission, it seems highly unlikely that they will mandate an autopsy. But that decision will be the coroner's to make. If the patient's death is a potential coroner's case, prior to speaking with the coroner, do not either move the body or remove or reposition medical equipment. As with the exam requirements, there may be differences in different jurisdictions, but in most U.S. hospitals, there are 3 pieces of physician documentation that accompany a death. The death note, which is brief and which should be entered into the chart shortly after the patient is pronounced. The death summary, which contains a more complete description of the hospital course and has a similar scope and format as a discharge summary. And the death certificate, which is the legal document for the county or state government. As the person pronouncing the patient, you are only responsible for the death note unless you are also the patient's primary intern, in which case you'll be responsible for the death summary. The death certificate is usually completed by the primary attending within 1 to 2 business days. What does the death note require? Not that much. So it should start with the listing of the time that you were called to pronounce the patient, the physical exam findings, which should explicitly mention the duration of time you felt for a pulse, watched for respirations, and listened for breath sounds. The date and time of pronouncement, which, as mentioned before, becomes the official time of death. A brief statement on probable cause of death if known. While the death summary and death certificate can go into more detail, the cause of death for the death note can be a short phrase like hypoxemic respiratory failure secondary to COPD or septic shock secondary to bowel perforation. Mention if family was present or notified. Mention if the coroner was notified, and if so, whether they decided it was a coroner's case. And if it's not a coroner's case, mention whether the family accepts or declines autopsy if they establish that decision already. And that's it. It should not take more than 5 minutes to write. All states have some protocol for establishing potential organ donation in deceased patients. However, every state is different. Finally, don't forget to let the patient's primary attending know about the death with a brief page. As a hospitalist, it is incredibly frustrating to enter the hospital in the morning and go to round on your patient, only to find that they had died 10 hours previously and no one had bothered to let you know. If it's the middle of the night when it happens, it's totally fine and often preferable to defer the page to the early morning.